goodness. I was looking at your bio. That's an impressive bio. I've read it before, but it is impressive. Well, I'm going to get started because this bio will take me a couple minutes anyway. So if you'll just leave that slide there, I'm gonna introduce our speaker today. And give me a second here. We've got Dr. Loretta Finnegan, Honorable Dr. Loretta Finnegan, who is president of Finnegan Consulting, Pregnancies and Substance Use Disorder and Neonatal Abstinence. Dr. Finnegan is the president of Finnegan Consulting, which addresses education, research, treatment, and issues relating to perinatal addiction. She is recognized nationally and internationally as an expert in this field. She is also accredited with the development of the assessment for neonatal abstinence syndrome, which we all refer to as the Finnegan scale. Dr. Finnegan received her medical degree from Drexel University College of Medicine, followed by a pediatric residency and fellowship in neonatology at the Philadelphia General Hospital, University of Pennsylvania Division, and then assumed the position of Chief of Newborn Services. At Thomas Jefferson University, she was the founder and director of Family Center, a landmark program providing comprehensive multidisciplinary services for pregnant and parenting women with substance use disorder and their children. As professor of pediatrics, psychiatry, and human behavior, she has directed research program to delineate the effects of and management for pregnant women with substance use disorder and their children in education of medical students and other allied health professionals. Dr. Finnegan has been the recipient of many awards, such as the NIDA Pacesetter Award for outstanding achievements in treatment, research, and the prevention of drug abuse, the AATOD Neiswander and Dole Award for the contributions to the treatment of pregnant women with substance use disorder using methadone maintenance, the Drexel University 100 Medal as a distinguished alumni, and the Surgeon General's Medallion, want to get that right, presented in 2018 by the First Lady of the United States, Melania Trump. The Secretary of Health and Human Services is Alex Azar, and the Assistant Secretary of Health, Admiral Brett Giroir. I always have trouble with those French names, for pioneering leadership and innovative performance as both a clinician and executive officer of the College on Problems of Drug Dependence and Development of the Finnegan Score, a groundbreaking key assessment for babies born with neonatal abstinence syndrome. So please, with that introduction, please welcome our speaker this morning, Dr. Finnegan.
Hey, good morning, everyone. Kristen, can we have the slides at this point?
Yes, pulling them up right now.
Okay, this is just the first one, so let's go to the next. So the title of my talk is Comprehensive Services During Pregnancy Complicated by Substance Use Disorder. Next slide. I don't have anything to disclose. Most of what you'll hear is basically presented from the literature or accepted protocols from research accomplished by me, colleagues, and other researchers. Next. So the objectives today will be the attendee will be able to incorporate guidelines developed for providing comprehensive services during pregnancy, outline positive outcomes of comprehensive care provided during pregnancy, review current dosing recommendations for methadone use during pregnancy, and describe benefits of comprehensive services for the fetus and the newborn. Next. Excuse this slide because I was too lazy to type all of them, so I just cut and paste, and I could never get them to line up. But basically, there's so much out there as guidelines, and I listed, of course, my first paper on this subject, which was in 1973 and later in 1991, and I'll refer to that paper again. And Dr. Andre Jones has a very nice paper in 2008 on the treatment of opioid-dependent pregnant women. There is a report that I did in 2013 for the Canadian Center on Substance Abuse that I'll give you the link, and basically it has a lot of good material in there, even though it's just basic material. And from 2013 to current, there are many more guidelines that you can look at. The World Health Organization guidelines in 2014, and then the paper by Dr. Jack McCarthy on the effect of methadone dose regimen on neonatal abstinence syndrome is an important paper for you to look at. And also SAMHSA and the NIDA.gov, and also the Centers for Disease Control just came out in 2021. So there's lots of information. Just go to the internet and look up these various groups, the Vermont guideline, for example. So there's so much out there for you to keep up to date. Next. But there are some dinosaurs that made some important contributions, and I'm one of them. I'm the pink one in there. Next. So the use of psychoactive drugs by pregnant women and their influences upon the perinatal period were a burgeoning problem in the United States in the 1960s. At that time, I was director of the NICU at the Philadelphia General Hospital, which was the municipal hospital for the poor of our city. And anyone could go with or without insurance. And at that point, I was a mother of 5 children. And that was when I saw my first baby in 1969, born to a heroin-dependent pregnant woman. And I guess for me, the story began at that point. Next, that is a young Loretta Finnegan sitting at her desk at the Philadelphia General Hospital. And those were my little ones at home. And next, I didn't know what was going to hit me when I decided to dedicate my entire time to the care of pregnant drug-dependent women and their babies, because at that time it was the heroin epidemic in Philadelphia. So next. I thought I didn't want to stay there. There are so many issues that heroin-dependent women were presenting when they were coming to the hospital that it was clear that they were high-risk pregnancies and they needed a multidisciplinary team approach so that one could help the mother and the baby. And fortunately, at that time, I had a grant from Maternal and Child Health. And it was a grant that looking at high-risk pregnancies using a team approach, an obstetrician, a neonatologist, a nurse, a social worker, and a nutritionist. Next. And of course, the idea came to me that I couldn't just, as a neonatologist, I couldn't just concentrate on the baby after it was born. I had to start when the baby was in utero. And then I realized that would be helping both mother and baby, which was obviously the most important thing to do at that time. Next. So in the 1970s, there were 2 programs in existence. One of them was Family Center, which was my clinic in Philadelphia, and the other was Pregnant Addicts and Addicted Mothers Program. Of course, we would never use that term today, but it was in the 70s, certainly an acceptable term. So the program was called that. And that was in New York. By 2007, only 19 states had created treatment programs for pregnant women. They were often male dominated. They were intrusive, they were exploitive, and they really were not designed for a woman and her baby. Next. The one thing that really was so impressive to us when we looked at our data was that, in looking at the chart on the right-hand side, with no drug use and prenatal care at our hospital, the incidence of low birth weight was 14%. With no prenatal care, it was 19%. Sadly, we still had about 30% of our obstetrical population who would just arrive at the time of delivery. But when you looked at the drug using population, it was 48%. 48% of pregnancies of those women who were using drugs were low birth weight. However, when we applied our services, the comprehensive approach, we could bring that down to 19%. And that was such an impressive number to me, the obstetrician and the social worker who were at that time the little team that was taking care of the clinic issues, that we just had to pursue it further. And we did receive more treatment grants and also research grants in order to do that. Next. Sadly, even though comprehensive services have been available, many women have experienced the opposite, that they could not be provided with such services. And what has happened over the years is that women who have used illicit drugs and or alcohol, or even those on methadone or buprenorphine, have been singled out for arrest, civil commitment, detention, prosecution, termination of custody or parental rights. Pregnant women were charged with child endangerment, assault with a deadly weapon, delivery of drugs to a minor, or reckless homicide. And in the 1980s, a new strategy to criminalize and prosecute women for drug use during pregnancy was brought on by the cocaine epidemic. Next slide. So when I began, I had no idea about what to do for the issue of drug dependence. We were not taught that in medical school. We were not taught that in internship or residency or fellowship. So that I had to begin from the beginning, and that was to try to find as many papers as I could, and listen to as many lectures as I could. Not that they were at the medical school, but there were other talks by individuals involved with public health. And this slide is from the 1970s. This slide, I thought, taught me what the issue really was. And you can see there are 11 issues. And when I looked at that, I said, this is truly a situation where comprehensive multidisciplinary care has got to be provided. So this, I think, gives you the picture in just one slide. Next. So while I was learning the ropes, as I say, as you can see, I love babies, and the hairdos are from the 1980s, as you can see, or actually this was probably before that even. But the three papers that are listed here, the 1973, the 91, and the last one was the one that has the complete scheme of what we were recommending for comprehensive services. Next slide. I was invited to write a paper for the bulletin on narcotics. And this is for the World Health Organization. And they gave me the title, Pathophysiological and Behavioral Effects of the Transplacental Transfer of Narcotic Drugs to the fetuses and neonates of narcotic-dependent mothers. That's a mouthful. But I wanted to just show you that at that time, I was recommending to government agencies and to medical professionals that we needed adequate funding for comprehensive services. And it was very difficult to provide them because there wasn't one agency that could provide all of the aspects. So one had to get grants from various agencies and also foundations. Next slide. So this is the scheme that we finalized in 1991. And you can see that it was important to have outreach services and individual and interpersonal, group, family, and other kinds of services, outpatient as well as residential. And as far as the biological and physiological, that included the prenatal services and the pharmacological issues, and psychological and behavioral and cognitive. Life skill management, we found clearly that the women had difficulties in problem solving, coping mechanisms, relapse prevention, social skill competence, and they needed to be educated with regard to pregnancy and parenting skills and child development and nutrition and social, cultural, and demographic, certainly survival management and sociological considerations, gender, race, social class, economics, and culture had to be included within the program. And housing, clothing, food, financial and budgetary, vocational and educational. So we had a food bank, we had a clothing bank, we had layettes for the babies. These were not things that research grants were going to provide, as you can imagine, but we were fortunate to get personal donors and also foundations that would. Mother-infant development, the mother-infant relationship was so important because we found that so many of the women had never been mothered themselves. So they had no experience. And then it was important to follow the babies after we provided methadone to the mothers and also the treatment of neonatal abstinence if it occurred. Next. So as things progress, this is now Dr. Emily Banstra in 2008 developed this cycle of care, and it's very, very interesting and has some good aspects that were not included in ours, but it's also a good plan of care. Next slide. And then in 2009, NIDA published the Principles of Drug Abuse Treatment, a research-based guide. And as you can see, again, many of the ingredients, as one might say, of the comprehensive approach were included here, as well as additional ones. We did progress. Next slide. And here in 2019, NIDA says the best treatment programs provide a combination of therapies and other services to meet the needs of the individual patient. And once again, you see many of those aspects that were in that 1970 cycle of addiction that was in the previous slide. Next. And of course, added to the comprehensive services were the pharmacological aspects. And over the years, we as you know, we have many medications that are available to us, but for the women, methadone and buprenorphine are both effective for in pregnancy and for the newborn. Next slide. I'd like to say just a few words about methadone. Next slide. First, I'd like to just honor three people that without them we would never perhaps had methadone or had it so early. Dr. Vincent Dole, a scientist and an internist, Dr. Marie Neiswander, a psychiatrist who took care of many, many addicted individuals, and Mary Jean Creek, a scientist and a clinician. They've all passed on. Sadly, Dr. Creek passed on just this last March, and that makes a huge deficit in the area of addiction and methadone and many other areas that she pursued. Next slide. Dr. Robert Newman, also a pioneer in the field of addictions, said Dr. Vincent Dole always thought first and foremost of the patients. Nothing took precedence over their needs and interest. It was the motivating and guiding force of all he did in the field of addiction. And I'm happy to quote him because many just think that Dr. Dole was a scientist, but he was a charming man, a brilliant man, and one who had the compassion to care for individuals who had substance use disorder, as well as Dr. Neiswander. And in fact, they enjoyed it so much they got married. And Dr. Creek she lived and breathed the research in this field. And it's a great loss to us. Next slide. And again, some interesting information that has come along as the years have progressed. Do different dosing practices using methadone affect NAS severity? This became such a talked of subject over the decades. You know, what about NAS? Well, first of all, the first patient one has to deal with is the pregnant woman, and we have to keep her stable. We have to keep her well, because that enhances the effect that will occur on the fetus and the newborn. So past reports in the literature had numerous statements regarding dose and its relationship to the severity of NAS. High versus low dose. Low doses decreased the severity of NAS was a going thing for a couple of years, but it was totally wrong because dose has no effect on the severity of neonatal abstinence. The fetus is exposed to the serum level, not the oral dose. If methadone is cleared rapidly, then the dose can be quite high, and yet fetal exposure quite low. And if maternal withdrawal equates with fetal withdrawal, can maternal withdrawal or underdosing or even single dosing during treatment sensitize the fetus to withdrawal or otherwise compromise fetal health? For example, stress the fetus during development. And these were questions that came along in the 90s and in the early 2000s. Next slide. We have a great challenge in dosing in pregnancy because there is a significant genetic diversity for enzymes that metabolize methadone. Pregnancy accelerates methadone metabolism. Absolute clearance of methadone is greater during pregnancy than postpartum, and methadone elimination is significantly more rapid for pregnant compared to non-pregnant patients with half-lives of 19 versus 36 hours. And serum methadone dilution and perhaps decreased absorption as pregnancy progresses decreases the effective serum levels. So we have all this to think about during pregnancy when we are dosing them with methadone or buprenorphine. Next slide. So can more sustained fetal serum levels with multiple daily dosing protect fetal health? and the problems at peak and trough serum levels and consequently reduce risk for neonatal abstinence. So what is the rationale for split dosing? Basically, more sustained plasma levels are achieved with twice daily dosing than by increasing single dosing. This produces 90% higher plasma trough levels and fewer withdrawal symptoms in mother and infant. Increased doses and dose intervals are recommended to compensate for the pharmacodynamic and pharmacokinetic changes in pregnancy. And there's so much data to show this. However, here we have the science showing that twice daily and in rare situations, dosing 3 times of methadone would be beneficial to the mother. And of course, we all know that in third trimester, some women may need an increase in overall dose. So there we are. We have the science. However, we have something called regulations. And the regulations at this point do not permit anyone to provide twice daily dosing. But we can get around that at this time until they finally change the regulations. And that is that we can ask for an exception for pregnant women. But unfortunately, it has to be done on a case-by-case basis. Next slide. There's a great impact on fetal welfare of maternal opioid abstinence, and we should avoid it at all costs because it decreases oxygen supply to the fetus, especially in the third trimester, and with the associated lifestyle and hypoxemia, this contributes to the occurrence of intrauterine growth restriction. And also, if the mother is withdrawing, the baby is going to be withdrawing, and that again will cause hypoxemia. Fetal abstinence is problematic for the fetus and the newborn, whether it arises from variable heroin doses or improper opioid maintenance treatment. So again, thinking back at the twice daily doses, we're basically not treating the pregnant woman appropriately if we do not use more than 1 dose. Next slide. And back again, you might say, well, why is a baby doctor discussing issues about pregnancy? Well, it's just this team approach of you have to help the mother in order to help the baby. And you have to start in utero. So the neonatologist is part of that team, along with the obstetrician, the nurses, the social workers, and nutritionists, and also specialist infectious disease doctors, for example. Next slide. This is a quote by Gottfried Herschel, who was the WHO director of HIV/AIDS in 2010. He said the child's health is inextricably linked with its mother. In pregnancy, we must realize that we are dealing with 2 patients, the maternal-infant dyad. And I quote him because he said it much more, shall we say, more beautifully than Loretta Finnegan just said it, but just looking at that, there's no question in your mind as to what we should do. Next slide. So what are some of the risk factors for intrauterine fetal death when the mother is using opioids? Well, there's low SES, inadequate prenatal care, obstetrical complications, hypertension, infections, and of course the effects of the illicit or illicit drugs today. Next slide. So pregnant women with opioid use disorder lack consistent prenatal care, and this puts them at risk for a variety of medical complications complications, and those that have the asterisk are those that are more commonly seen, such as anemia, septicemia, cellulitis, phlebitis, urinary tract infections, sexually transmitted diseases, and hepatitis B and C. But you can see there are a host of issues that one might have to deal with if the mothers do not receive prenatal care. Next slide. And along with the medical complications come the obstetrical complications. And again, the ones most commonly seen are shown with the red asterisk: early pregnancy loss, intrauterine growth restriction, late intrauterine death, premature labor, and premature rupture of the membrane. Next. And again, psychosocial issues are seen. Physical and sexual abuse is so prevalent, and we'll discuss that a little later. Family dysfunction, chaotic lifestyles, low frustration tolerance, homelessness, and some may be involved in drug dealing. Next. The delivery is so important, and how the delivery can be handled is so different if the mother has never been seen by a physician during pregnancy. But to just come in and deliver a baby, the medical professionals have no idea as to what has come before and what medications they can use. And so it makes things very difficult. I review cases for the Office of the Public Defender as an expert witness in defense of the mothers and the babies, because the state of New Jersey sadly has a rule that says that if a baby goes through withdrawal, that means the mother has harmed and abused the baby. So that means if any baby that goes through withdrawal, whether it's because of buprenorphine or methadone, has to be investigated. And in some cases, fortunately, we can get most of the ones that are on buprenorphine or methadone to have their babies, but sometimes there's a delay. But in any event, in the cases that I review, in those mothers that have not had prenatal care, just a recent one, her baby was breech and she had a ruptured uterus during the birth of the baby, and of course a C-section was done. But it's amazing that both mother and baby survived because it was a very tragic situation. Next slide. The one thing that we see today, and we also saw it back in the 70s, because all mothers smoked nicotine and some smoked marijuana, but they were on a lot of heroin. And then in the 80s, the cocaine epidemic began. So they were on cocaine and heroin and nicotine and a host of things. So that opioid use disorder is rarely seen in the sense of it's pure opioid use. It's generally poly drug use, which makes me wonder how the term neonatal opioid abstinence syndrome has come about, because I don't think there is such a thing. There is neonatal abstinence syndrome, which encompasses all drugs that mother to which the baby is exposed. But we seem to enjoy changing names over the last few decades. You know, I wish we would progress in other ways instead of just changing names. Next slide. Prenatal care is key for mother and baby, and there are a lot of risks to opioid-dependent babies, opioid-dependent women's babies who do not have prenatal care. And again, the asterisks show the most common: prematurity, intrauterine growth restriction, perinatal asphyxia, and poor mother to infant attachment. And Congenital malformations do not occur with opioids, but if the mother is using alcohol concomitantly, there is a chance of the fetal alcohol spectrum disorder. Next slide. We want babies to stay in the uterus for the full time because if they're premature, immediate and long-term morbidities and decreased survival may occur. Next slide. And for low birth weights and heart disease, we know that perinatal health can affect a person's risk of heart disease many decades later. Infants with low birth weights can develop heart disease as adults. And as you can see that if they're over 8 pounds, it's less, it's 4% or less. But with 5 pounds, it's up to 15% that can have future heart disease. Next slide. A third of infants with IUGR have diminished growth, mental and or motor disabilities. So again, we want to avoid a baby who does not grow appropriately in utero. Next slide. We're all aware that substance use disorder and mental health illness can occur concomitantly. If you look at the red circle, that's mental illness, no SUD, and the yellow is SUD and no mental illness. But the orange area, you can see a significant number of individuals have SUD and mental illness. Next slide. It's estimated that 2/3 of women with opioid use or with substance use disorder also have concurrent mental health problems, such as anxiety, depression, post-traumatic stress disorder, and panic disorder. Because pregnant women are susceptible to tremendous emotional changes, pregnancy is a time of heightened vulnerability to the exacerbation of pre-existing psychiatric conditions. And so this is, of course, a very important component of comprehensive services. Next slide. Over 90% of women with substance use disorder have experienced lifetime trauma. In listening to the woman that I had in my clinic, when they left my office, I would be in tears because I just couldn't imagine if I could ever make it in life, looking at what they had to endure as children, as adults, with the trauma, whether it was physical and or sexual. Next slide. Well, untreated opioid use disorder can disturb mother to infant attachment, and I think we all know how important this is. And remembering also that this is a two-way street. It's the mother to the baby and the baby to the mother. So that can we see in the mothers? First of all, they have anxiety over the baby's prognosis. They have anxiety over social authorities, especially in some states, like the state I live in and many other states, where they seem to have the goal of removing babies from mothers who have substance use disorder. The mother may be intoxicated. She may be in withdrawal. She has difficulties with relationships. She has low self-esteem and depression, ambivalence and sense of guilt, problems with paternity, lack of breastfeeding, and they're separated from their baby. And the neonate may have a condition that makes them less responsive to the mother, such as prematurity or IUGR, asphyxia, infections, withdrawal signs, medications that they are given for NAS, and they are separated from their mother. Next. So the last part of comprehensive services include a multidisciplinary team, and all of the individuals on the left, including consultants that you may need, as I mentioned before, such as infectious disease physicians, are important. And groups are important to discuss life skills, parenting, relapse prevention, problem solving, coping, parenting, childcare and child development, women's health, neonatal abstinence, and stress issues. Next. There are lots of positive outcomes for comprehensive care for mother and baby. And I think that you're certainly aware that for the mother, you can decrease the drug use, increase the time in for prenatal care, and decrease morbidity and mortality, HIV and HCV risk, improve prenatal care and healthier pregnancies, and improve self-esteem and depression. And for the baby, the big thing, as I mentioned before, is that you can improve the birth weights and also decrease infant morbidity. And we have a chance to control neonatal abstinence and improve maternal child interactions, which are so important for the child and the mother. Next slide. And currently, of course, every decade we seem to have yet another issue that comes forth, and people with a lifetime or recent SUD diagnosis are more likely to contract COVID-19 than those without substance use disorder. And in the graph, you can see the blue bar, which is opioid use disorder, and you can see both with lifetime SUD and recent SUD, there is an increased risk. Next slide. So women with opioid use disorder do care about their babies in utero and after birth. There's so many that feel that the picture on the left of the mother who's pregnant with a cigarette in her hand is what to expect. But actually, if you look at the other pictures, these mothers care, and they do prepare with the furniture, with the clothes, with even little shoes for their babies. Next slide. So you should consider pregnancy and opioid use disorder as a window of opportunity for treatment and recovery for women and babies, because it really is. Because all women who become pregnant are concerned. Some are more concerned than others, but one can discuss that issue. How do you feel about your baby? And they all will say they want a healthy baby. Next slide. So our aim should be to treat the issues identified, which will result in, sorry for the phone. So our aim should be to treat the issues identified, which will result in healthy and happy maternal infant dyads. Next slide. So in summary, what is comprehensive care in pregnancy with substance use disorder? The comprehensive multidisciplinary treatment services for pregnant women who abuse drugs have demonstrated numerous positive outcomes for the mother and baby, including adequate prenatal care, improved maternal nutrition, reduced risk of premature birth, and decreased maternal and infant morbidity and mortality. A multidisciplinary team is able to provide this. A comprehensive treatment approach is one that combines a variety of services, including medical and prenatal care, addiction counseling, psychosocial supports, trauma-assisted services, family therapy, child care services, transportation assistance, food, and clothing banks. The stigma associated with drug abuse, particularly among pregnant women, presents a significant barrier to assessing treatment. Supervised medication-assisted treatment with methadone or buprenorphine is an effective component of a comprehensive treatment plan for pregnant women who use drugs. Ongoing research continues to evaluate how infants are impacted by exposure to such treatment. Mothers undergoing medication-assisted treatment can breastfeed their babies except in certain circumstances where there is continued concomitant drug use or HIV positivity. Next slide. And so additional thoughts for comprehensive services. It's costly, but what is the life of a mother and baby worth? If recovery is the goal, it is important to cover all aspects of the addictive process: physical, psychological, and sociological. Pregnant women with SUD need intensive counseling because of early trauma. Medication only is not enough. Always remember to be non-judgmental, compassionate, and comprehensive. Next slide. This link will get you to this particular book, which is the 2013 report that I did for the Canadian Center on Substance Abuse. It has a lot of good basics in it. It's from 2013, so you've got 8 years of additional research, but it might be useful to some. Next slide. What we should be doing in developing adequate programs in quantity and quality for maternal opioid dependence, providing comprehensive services which will produce healthy mothers, healthy babies, healthy families, and decrease fetal stress. Next. More reason for concern: 91 Americans died each day from an opioid-related overdose. And that was in 2017. And you know now it's even worse with all the fentanyl that's coming into our country. Next slide. So the opioid epidemic, why should we be involved? And over 20 million Americans have a substance use disorder, yet 90% of them do not receive treatment. So we need so many more professionals to be involved in this area. It is one of the major issues with regard to the health of Americans. Next slide. The bad news: global spread of neonatal abstinence syndrome from 1980 to 2021. It's all over the world. Next slide. So the good news is, as my family grew, and this is a 2011 picture, so it's outdated, I now have 18 grandchildren and 2 great-grandchildren. So as my family grew, so did the scientific attention to NAS and treatment of women for opioid use disorders during pregnancy. So I'm down there where it's 1970 and 1980 with regard to the black dots, which are the NAS publications, and look at those with regard to opioid disorders during pregnancy. They really have gone up. And this ended about 2019. And I can tell you that it's hard to keep up every day with all the papers that have come out. So that's really terrific news. Next slide. So Felice Leonardo Leo Buscaglia said this. He's also known as Dr. Love. He was an American author and motivational speaker and a professor in the Department of Special Education at the University of California. He said, "Too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around." So there's our task. We've got to turn some lives around. And I thank you for your attention.
Thank you, Dr. Finnegan. I think that's probably where our next venture will be in the future, because too often people are just at that breaking point of being stable versus not quite yet stable. And that last slide speaks volumes to the actual need of the two being together and in the continuation of recovery. And unless somebody's very stable or deemed very stable by DCS, they're likely going to have their babies removed. And so it's a scary venture to, you know, have a baby stay with a parent that is not stable, whatever that means. And yet that's often where they get completely derailed in their recovery. So excellent point. Thank you. I know we had one question from Karen, which was, I'm curious to know how you feel about the eat, sleep, and console model that is beginning to become more common.
Oh, am I on? Can you hear me?
Yes.
Okay. Well, first of all, my philosophy is that there isn't just one way to treat, whether it's neonatal abstinence, whatever disease entity. We have, look at how many medications there are for hypertension. I think it's something like 200. So that there are different methods. And I just happen to favor a score, because with the score, I think that most people are not aware of the fact that we have supportive measures. I have a whole chart that we published in 1975, which basically does a lot of what Eat, Sleep, and Console does. In other words, the console part of it. So one must console and do the score. You don't just do the score. So that most of my experience is there. I commend those the researchers that have Dr. Grossman and I think Elise, forget her last name, but anyway, they put together a wonderful package looking at Eat, Sleep, and Console. The main thing in that, as well as in anyone who uses any of the scores that are out there, is inter-rater reliability. It's so important that everyone is oriented, that in-services are done routinely so that everyone is doing it the same way. So that's my feeling about it.
Thank you. That's great.